Well, with that, my phone says 1 o'clock, and I know everybody is always busy. So I just want to kick this off, and we'll let people join us as they can. I first want to thank all of you. It looks like we have about 45 people so far on the call for just carving out this hour. I hope you find it informative, and I can't tell you how much we're looking forward to just having a dialogue with all of you. So again, thank you for taking the time. I made a little note because our audience is really very vast, and I'm very appreciative of everyone from various places in our community that decided this was worth their time. So quickly, we have people joining us, some judges, thank you, parole and probation, all of the hospital systems, insurance companies, the faith community. We also have people from OMAS and the U.S. Attorney's Office, and the Healing Project, which is something that is passionate and close to my heart. Lucas County, we have folks from our Lucas County Mental Health Board and our health department, and also some participants from the VA. So that's just kind of a quick overview of the audience. And again, I just want to say thank you and welcome. And Katie, I'm going to have you flip the slide to agenda, please. And so again, no need to read it to you. It's up, and I hope everyone can see it. But I do want to set some ground rules so that you guys all are aware. We are trying to record this, and we are recording it. So if you would like to turn off your camera, if you don't want to be seen, that is just a decision for you to make, but just kind of a issue if you want to remain private. To keep this on point, we're going to ask when you have questions that you just simply put them in the chat. And then I guess I am the official moderator. So when we're done with kind of the quick presentation, I will start selecting questions from the chat, and or if we think it's easier, we can unmute if you have something that you really want to share. But it is meant to be a conversation and not just a download of information one way. So again, be thinking and scribble things down if they come into your mind when we're speaking, and or better yet, put it in the chat. And so with that, I just want to thank, as we go to the next slide, I'm going to turn this over to Dr. Ryan. I just want to thank Dr. Ryan, Dr. Kang, and Nate Pellier from our company, BrightView Health, down in Cincinnati, because they're really the folks that you're going to be hearing from today. I will just kind of keep it moving. And Katie, thank you for administrating the slides. So with that, and without any further ado, I am going to turn this over to Dr. Sean Ryan, who is one of the founders of our company. Dr. Ryan?
Hello, everyone. I'm Dr. Sean Ryan, the founder and chief medical officer of BrightView Health. As you can see here on this slide, I'll be actually joined today by one of our other key executives, Dr. Nav Kang, and at the very bottom there you see my co-founder, or one of the co-founders, Chad Smith, as well. As stated, I'm the founder and chief medical officer of the organization. I'm not going to read the slide to you, but just know that I'm a board certified emergency and addiction physician, founded BrightView based on some key principles, as well as the need to substantially increase access to high quality treatment for substance use disorder. And we're going to talk about those things in the next few slides. But this is a little bit of the executive team. We're very blessed to have a robust and highly capable executive and management team at BrightView Health that guide us to meet the mission and vision of our organization every day. Next slide, please. I'm going to talk a little bit about our core functionality, our mission and vision at BrightView Health. What we really do every day, and have for several years, is what we describe as comprehensive outpatient addiction treatment. This strategy was born out of the need that I saw several years ago, starting in Cincinnati and now all across Ohio and Kentucky. It started in Cincinnati basically as an emergency physician years ago, very frustrated with the quality of care in relation to mental health and addiction, specifically obviously focused on the opioid crisis for the past several years, but really broadly what I would describe as unfortunately inadequate both speed to treatment as well as quality of treatment throughout a lot of our state in Ohio, as well as throughout the country. And so we focus our treatment delivery on the clinical research and best practices that are laid out in the medical evidence, as I always have. As an emergency physician, that was very much the focus that we had to maintain in delivering high quality emergency care at the University of Cincinnati, where I was originally based. And we've taken those same thoughts and translated them into the research and best practices that we deploy at BrightView. You can see the three core functions that we deliver to each individual that we take care of, and that's what we call a biopsychosocial model, or the medical, psychological, and social components. And we deliver those as a holistic treatment plan to every individual with substance use disorder that we come across. One of the most important pieces I've briefly mentioned is the fact that, and again, somewhat based on kind of an emergency medicine mindset, we really deliver high quality addiction treatment on demand. What that means is pretty simple if you think about the individual, wherein a lot of times when folks are ready, they need treatment then. What was not the case at all several years ago, and still continues to be the case in too many parts of our country, is the fact that folks can't get access to high quality evidence-based treatment when they're ready to receive it. And we have a pretty long way to go as a state and as a country to get to the point where those services are available readily when the patient is in most need. We do commit to the community, recognizing that especially addiction, and particularly the opioid crisis, has devastated many communities, many community members, families, friends, myself included. We've all had someone that we know that this has happened to. And so we understand this is a community issue, and we do make sure to collaborate with our partners in regards to that issue. We have a strong emphasis on criminal justice partnerships because we know that unfortunately a lot of patients with substance use disorder do get involved with the criminal justice system. We also interact with county boards, coalitions, and other entities that are working to deal with this issue in their community. And we spend a lot of volunteer time on for different endeavors, making sure that we are lending our expertise in whatever way necessary that's possible. An example of that is we coordinated the largest Narcan distribution in the United States that's ever happened. We did that in conjunction with the University of Cincinnati and Hamilton County Public Health as an example, and recently won a national public health award related to that effort. I mentioned the things, kind of the last point on this slide, the ease of access and treatment on demand. Just know that we recognize when people are ready, they need to receive compassionate acceptance, and that's what we do with a 24/7 call center and ready acceptance of people walking in or making appointments at any time. Next slide, please. One of the things that we're attempting to develop, as an entity as well as with partners, is establishing an actual continuum of care for substance use disorder patients. So if you think about the continuum of care for other diseases like diabetes, asthma, cancer, any of these, we are very blessed in this country to have one of the most amazing medical care systems in the world, albeit a little expensive sometimes. We don't have that same continuum of care for substance use disorder patients where we're sure that they can get emergency care and then ongoing care and all of that delivered in a fairly connected and comprehensive fashion. So we know that the continuum of care has to continue to be developed. We have focused our efforts on the what you see here as components 1 and 2. Those are ASAM levels, or American Society of Addiction levels 1 and 2. And it's outpatient and intensive outpatient. We coordinate with partners who deliver residential and inpatient treatment and believe that those are a necessary part for some individuals that require care. But according to the science, only about 1 in 5 individuals needs those level of care. And so we focused on the other 4 out of 5, and knowing that patients will need ongoing care for basically for some long period of time in their life as they go through their journey of recovery. I did want to mention that unfortunately, detoxification alone has not been shown to be effective by itself. It can be an important component of a treatment plan, but if an individual is given or taken to and only given detoxification and not ongoing care, they actually have a higher chance of mortality, which is absolutely the wrong way to go. So we just wanted to call out the fact that we serve a certain part of the continuum, that you can see here, but we recognize that there's more care necessary for some patients, and we coordinate that with our partners in the field. Just a little bit about the medical component of our holistic plan, and Dr. Kang will speak to other issues related to the remainder of our holistic treatment. We really do follow the best practices as soon as they come out and are established in the field as the right science-based treatment modalities. That does include, for a large number of individuals, particularly with the opioid use disorder, medications. Now, there are 3 FDA-approved medications, which you can see here: methadone, buprenorphine, and naltrexone. We do utilize all 3 of those as indicated for each individual patient when we're presented with their case. And we're very blessed to have a large group of addiction specialists, many of which, like myself, are double or triple board certified in internal medicine, emergency, OBGYN, et cetera. And we use that team to ensure that we are delivering the absolute best evidence and medication decision plans to our patients at any time. We also focus on other issues related to infectious disease, and we end up, as you might imagine, taking care of some medical problems as we're stabilizing patients from their active addiction. We do make sure that we are following all guidance in regards to the medications that we choose. And these cases, as you might imagine, again, can get quite complicated. It is not an accurate statement to say that each patient can be maintained on any one of these medications, meaning each individual has their own complex set of psychosocial and physical needs. And so that's what we really are, again, proud to say. We have the largest network of addiction specialists of any entity I'm aware of, specifically in Ohio, and that allows us to be very specific, targeted, and accurate in our medication decisions for patients. And we do coordinate those decisions with the rest of the patient situation as much as possible and as much as medically indicated. Probably most importantly, on the right side of the slide here, you'll see that we don't wait to get patients these medications when they're indicated. So what that means is, unfortunately, I've seen in several agencies or entities, sometimes the patient will not receive the appropriate medical treatment urgently, and that is just unfortunately not the best practice for many patients. And we really do strive to make sure that if we're managing a patient withdrawal or whatever other medical related issue they might have, that we are doing that in a very timely fashion and doing so to meet the needs of the patients at that.
Very much appreciate the opportunity to join you all. A little bit on me. I'm a psychologist by training. Spent the 6 years prior to coming to BrightView with Mercy Health down in Cincinnati. So obviously Mercy Health has a reasonably large presence up in Toledo. And so some of my colleagues in the Toledo market for Mercy Health are probably pretty well known to many of the folks who are on the line with us today. Primarily functioned on the inpatient side with inpatient psychiatry and psychiatric emergency room services. And I think we did a lot of nice work in that regard, and also in the integration of psychologists and psychiatrists into the primary care setting. Pretty nice innovation that we had the opportunity to engage in. But Mercy Health and many other large health systems don't have as much capability when it comes to the treatment of folks with substance use disorder. In other words, didn't really have much in terms of like a continuum of care or certainly a comprehensive outpatient addiction treatment service. And so had the opportunity to meet Dr. Ryan and the BrightView team and stand up that continuum of care that he referenced on the earlier slide down in Cincinnati. And I think influenced the way that the healthcare system responds to people with addiction in a more well-informed and compassionate way. And so came to BrightView a little over a year ago now to help take the clinical service line to the next level. So I think probably for most of the folks who are on the call with us today, you guys will be interfacing mostly with the clinical team, although Nate, who's going to speak in just a moment, also has a small team that works very closely with the clinical service providers in the centers. to make sure that our communication to interested referral partners and to others who are stakeholders in the patient's care are well informed about what's happening with the patient. So he'll speak a little bit and I think give you guys a little bit more about like what to expect from us as you collaborate with us on the care of the patients that we mutually serve. But I'll give you a little bit of background on our clinical services so that you can understand the depth and breadth of that. So as a foundational piece, we typically like to hire folks with a master's degree. So over 90% of our clinical providers have a master's degree. We really look for folks who are well trained, not just in the treatment of folks with addiction, but in also the treatment of mental health, co-occurring mental health. In the end, it's very difficult to somewhat artificially separate a patient's mental health needs from their addiction treatment needs, and so we really look for well-versed staff who are able to treat basically everything that walks in the door. So similar to how on the medical side we have, collectively hundreds of years of experience, as Dr. Ryan noted earlier, we have a significant amount of experience in our now well over 100 counselors, therapists, social workers, et cetera, that we have across the BrightView system. And so each of our patients receives the entire comprehensive model. I think that's important to note that the patient who comes in today, right now, walking into any of our centers, including the one in Toledo in Maumee, would be seen by our medical team and provided with the excellent care that Dr. Ryan described earlier, but then would also be seen by a counselor. They would have their initial assessment done today as well, and they would begin the process of treatment planning on an individualized level. What does this patient need in order to take the next steps towards recovery? Some of that stuff is very fundamental, candidly. I think most folks can appreciate. We have some folks come to us who are quite ill when they're first starting their treatment journey. And so we ask questions like, do you have a place to go tonight? And if you don't, we will help to solve that today. Do you have a way to get back here tomorrow? Because many of our patients need to come back as soon as tomorrow and see the entire team again, see the medical team again, see nursing, see the counselor again, because the level of acuity is so high. And so if the patient doesn't have a way to get back the next day, we problem solve that as well. And then obviously in the medium and long term, we look at addressing a number of other issues. So whether it's food insecurity or housing earlier in the process, or it is getting ready for a job interview, preparing a resume, later in the process, signing up for insurance somewhere in the middle, doing some family reintegration work clinically. We really try to run the gamut when it comes to what the patients are going to need from us. From a purely interventional standpoint, we offer a variety of modes of treatment, so individual counseling, group therapy, family, couples. Obviously on the family and couple side, it can be difficult at first to even access family. A lot of folks have burned bridges before they come to us, but we really believe that folks exist as part of a system, and not just in the system in terms of like the services that are out there in the community, but their own personal system, their own personal network. The health of that could be poor when a patient comes to us, just like their physical health, but we should seek to attend to that facet of their well-being as well throughout the course of treatment. And so patients start typically with a pretty intensive course of treatment, a lot of it being informed by what are they able to actually access from us in terms of how often can they come into the centers. But a typical patient who's in an intensive outpatient service with us will be on site multiple times a week for multiple groups, and also be receiving individual counseling in addition to the medical services and case management services that we offer. And then later, as folks stabilize, then we pare back some of the intensity to weekly counseling, something that looks a little bit more typical to I think what folks expect in terms of long-term chronic disease management. And we really work with folks to make sure that there are each piece of treatment is additive on what has been learned before, the skills that have been developed in the past, so that folks feel like they're actually gaining something from treatment. I think we always say, as any of us would with any service, you engage with it at the level of which you derive value from it, right? So if folks weren't finding value in the service that we provide, we would expect them to probably disengage from the service that we provide. So we really like to make sure that that patients are continuing to grow. And we use a variety of measures in our treatment process to inform how are we doing with that? Are patients actually getting better? And do they feel like they're making progress? And if not, how do we problem solve around that? And if they are, we also check in with them. According to these assessments, it looks like you're doing better in the following ways, but according to these assessments, it looks like you're still struggling in the other areas. How do we work on that? And so providing a lot of transparency to patients in that regard is key. On the right-hand side, by the way, you'll see one of the notes that we have around our outcomes. There's a variety of metrics that we can share in this regard. Patients have extremely statistically significant changes on a variety of measures very early in treatment. At 3 months, 6 months, 9 months, 12 months, patients feel remarkably better the longer that they engage in treatment at BrightView, and those gains are maintained clinically at a year plus. And so we're quite proud of that, and we seek to share that with patients and also provide them with hope that the work that we seek to do here can really be life-changing, as evidenced by thousands of data points that we have accrued on thousands of patients over the long term. So when it comes to our comprehensive model, I don't want to overly belabor the point that Dr. Ryan shared earlier. We really just follow the science, right? So we're not seeking to reinvent the wheel here, but we use common sense to remove barriers and assess people in a holistic way, not just providing one singular service that we think will somehow resolve everything that they have going on. Addiction is complex, and frankly, people are complex. And so we believe that our treatment needs to be just as complex and just as thorough as those needs would warrant. A quick note before we go to the next slide on harm reduction. I just want to be clear on this one that basically our thought process is that we can't treat someone who's dead. And so in order for us to live some of that understanding out, we make sure that folks are provided with treatment at the level that they're able to engage, and then titrate treatment up and down depending on how well patients are doing with that over time. And so we don't blacklist people from treatment. We don't fire people from treatment for struggling with the condition for which they sought our help. We don't do that in any other area of healthcare, and we don't believe that those kinds of tactics have a place in addiction treatment. So just like how the earlier slide mentioned that wait lists don't have a place in the service that we provide, the proverbial blacklists also don't have a place in the service that we seek to provide with. So a quick note on telehealth and virtual care. I'll sum it up by just saying that telehealth is certainly the price of admission to be in the business of healthcare nowadays. The good part for us at BrightView was that we were doing telehealth for a long time before the coronavirus pandemic. And so it was less for us about figuring out the technology or trying to choose a platform or determine how is this going to work, how do we make a connection, all of that kind of stuff. And instead, we've really been focused more on second order problems when it comes to telehealth. In other words, how do we develop an adequate therapeutic relationship with patients when we're doing one-to-one video visits or one-to-one audio counseling? If we're doing a virtual group and we have a number of people who are on the screen, kind of like we have right now, and we're sharing some materials on the screen and the pictures of folks are small on their devices, how do we make sure that folks feel safe and comfortable in a setting like that to be able to develop adequate group cohesion and really feel like they're connected to the other members of the group? And so we've really endeavored to look at those clinical issues and develop our team's skill set so that they become better therapists, not just in the individual or the group setting in the traditional sense, but also in the more, modern and what we're going to see more of in the future version of therapy delivery, which is going to be through telehealth. So a quick summary on this really is that everything that you can do in person, we can find a way to do remotely. Now, Currently, most of our services in that regard are centered around our brick and mortar locations. So a patient is still quote unquote like attached to one of our locations and has a team there. They may come in for occasional medical visits, and they'll come in if they're part of our on-site opioid treatment program, the on-site pharmacy, in order to pick up their medications. But separately, one of the innovative services that we'll be launching here in the next month that we've devoted quite a bit of leadership, executive, and management resources and bandwidth towards is a new service line that we're calling BrightView Virtual. Very creative, right? So the idea there is that can we find a way to serve patients comprehensively in the long term with a purely remote service? And we think that we do have the makings of that in terms of workforce, in terms of expertise. And so for those patients who are in rural settings, or those patients who are in an urban setting but struggle with transportation and there just are more difficulties in reaching those folks, how do we take telehealth and make that be something that is either an intermittent piece of their care? How do we make that a regular cadence of their care? Or how do we make that something that is basically the totality of their care? We're really looking at trying to solve those problems so that we can take this whole question about quality and access to the next level. Next slide, please. I'll hand it over to Nate. He's going to talk a little bit about some of the tactics that we use in terms of coordination.
Well, thank you, Dr. Kong. I appreciate it very much, and just delighted to be on this call with all of you. It's great to see the turnout. Talking, kind of moving from, the BrightView and what we've done internally and what we're doing to continue to improve into externally and how we're partnering more completely with all of you, particularly in the criminal justice network. What we've seen, just to kind of give an overview, as BrightView has grown, and we've seen the dynamic, patient mix that we have, and realizing how important the criminal justice patients are, and really what we say is co-treating them. So we know all of you from the probation, parole, and courts are really treating these folks by, investing in them to go to treatment. And we feel that there's an interconnected relationship there that we need to be very cognizant of and honestly do better. So what we realize, and really what I'd say in truth here, is that throughout the few years that we've been had a presence, I think, beyond just the Southwest Ohio, is that we really need to focus more on the partnerships that we have in the communities that we're going into, particularly here in Toledo. So we saw that as we are treating patients, and we know we're providing these great services that Dr. Ryan and Dr. Kang had talked about, that often there's a operational component managing criminal justice involved patients that can really impact them if we don't pay attention to it. So, and that comes in the form of making sure that we are accounting for them and communicating to the partners, all of you, how well they're doing, because that is important in managing all of their aspects, not only what they do in treatment, but all the things they have going on outside, particularly as they're involved in the probation, parole aspects of their life. So what we have done really is looked at from BrightView's standpoint is where can we really do better? What are the things that are really driving us to have a strong relationship and partnership to ensure that we are co-treating these patients that are involved in the criminal justice system? So without going through all the details, we really spent a lot of time with the folks like Jean in each community who have the relationships with all of you, and to really figure out what is really driving, what would drive a successful partnership. And it really came down to two things: having strong communication and accountability. So communication to all of you and making sure we're accountable to all of these patients. And we went through what I would say is a very robust kind of analysis of how well we're doing across all of our sites. And we found out in many locations that we really struggle to keep up with the communication aspect and to make sure patients are accounted for on the outside with all of you, and being able to communicate with you effectively when you need that communication. So as we went through, we really identified, how often do we really need to be communicating externally? Is it a month too much or too long, or is it weekly? we really came to the conclusion looking at it is that, on a 2-week basis, that if we can get reports out on the status of patients involved, that they're going to more or less fall right, within the time frame that you need to have that communication and account for that person in your own processes. So we decided to really look at and build a system that would make sure that across all of our sites that we're able to get reports out even without you having to ask for them on a bi-weekly basis. And to do that, we really had to operationalize it within the company. We created an online form for all of our clinicians to be able to do that on a bi-weekly basis and to get those reports out to you. And then we looked at each region, particularly here in Toledo. It's like, well, when is it most important that you have it? Is it on earlier of the week or the end of the week, based off of how the community operates and when the patient has appointments? So as we went through that process, we realized that this was quite a task for our clinical team, given the volume at many of our sites, even at Toledo, of how many patients were involved in the criminal justice system. And it was difficult, more or less, to keep up. And in order to really resolve that, in realizing how important it is to maintain that level of accountability, we decided to actually centralize this and create a role. We call them the case management specialist role, which is really framed at a person who will specifically, in all they do, is focus on the criminal justice patients that are involved at BrightView and making sure that all of you get the information you need when you need it. So we just launched that role recently within the last month and a half. And we intend to have that role cover all of our sites throughout the state of Ohio. And where we are right now is that we had just hired someone in the north part of the state, and that will be covering Toledo in the next few weeks. So what you should expect from us is that we will have someone that will be able to reach out to you directly, and we'll be managing those communications to ensure that you get the information you need when you need it, and to address any of the issues that you have in the system. So some of the issues that we see and that we tend to address are sometimes very, very basic. So you hear the magic word all the time. It's the rule, having the ROI, right? Being able to have that in place and having it correct and having the patient sign it so that we can begin the communication. It seems like an easy task, but it sometimes isn't. What we've asked is that on our side, if we identify a patient that is involved in the system, that we make it a clinical intervention. Oftentimes folks are not always willing to sign it. They are scared. They feel like it's a threat, but we know how important it is for them to have that communication, collaboration, and accountability with all of you in order to also be successful in our program. So we are continuing to work that and to work with you on that as well. One of the big things that we've done to ensure that the ROI is as seamless as possible is to actually digitize it. So you probably heard Jean talk a lot about our digital ROI, and why that is important for us is that if you can fill that online, it is it's an instantaneous resource. As soon as it fills out, it goes right into our system, and we can account for it right away. But most importantly, what it does is it reduces error in the ROI, right? So you have to fill it out correctly. You have to fill out each component before it will allow you to save and send. And that way we can make sure that the ROI is correct, it's in our system, and we don't have to have this back and forth of figuring out where the ROI is or if it's not filled out correctly. And that way allows us to collaborate on a more seamless basis and to get the information and reports that you need on that patient. So that's a really important process. 3 things that we've realized that are from our patients that 3 different categories that they fall in as far as engaging in our company is that, well, we know that oftentimes that you will refer people to BrightView, and we call those referrals, and that information will be initiated often from you. But there's times in our system where patients, we are not referred from you. They come from the hospital. They come from, a walk-in. But we need to identify that they still may be involved in the system. So we've developed a process within our company that we continue to ask those on day 1 when a patient comes in, if they are involved in the system, so that we can initiate and find out if they have a probation or parole officer. so that we can continue and initiate the process of communication and accountability back to you. We found that that was a barrier because if we didn't ask those questions, you would assume that you don't care if you refer them to us or not. You would assume that BrightView would figure that out. So that was a major learning for us as well. The other category too is that sometimes patients they may not be involved when they come in, but unfortunately later in the program something happens and they are. Well, we have to be able to identify them later in the program as well. So we have built into our system that when the counselor is meeting with the patient, part of the check on the treatment plan is to ask that question: are they involved in the system or not? And that just allows us another opportunity to be able to identify a patient and begin the process, getting the ROI in place and adding a report for them in contacting the probation and parole officer or the court in this case to make sure the process is seamless. So these are all really things that we've done that seem pretty low-hanging fruit, but across multiple sites, when you have a high volume of patients, can be really challenging to coordinate. So we are really proud of the process we put in place. We look forward to putting in a case management specialist up in the Toledo region to own this process specifically for you, so that we can ensure that you get the information you need when you need it. And ultimately, it's the best thing to do for the patient as we co-treat them, both to reduce recidivism in the criminal justice system, but also to keep them and reduce recidivism in their treatment as well. And I look forward to taking questions on this in the forum as we move forward. Jean?
Thanks. And Katie, thank you. So real quick, back to me, and I'm just going to touch on this information because I think it's important, and I think many of you on the call are familiar with it, so please bear with me. But the NPS system, I think you've probably heard it in many different ways, but we are all about feedback and listening and improving. And so we can't do that without good folks like you. And so we use a system that many of you as my referral partners have gotten a questionnaire sent fairly regularly on how you think it's going. And then we use a similar tool in our center, which I'm equally excited about, which is where we ask the people we're helping how they feel about us, really. And I will say, as a referral kind of marketing person, it's what they're saying as well as what you're saying that really rock and make my day, because it's usually very favorable. So thank you for that. A couple examples on the slide. The beauty of everything that we're trying to convey is that we're responsive. And that means a lot to me, that I have an organization that's kind of pushing the envelope in this industry that I work with. And when they hear something, we try to solve it. And I think there's a lot of issues. Everyone on this call knows there's lots of barriers and breakdowns, but we are all about taking and trying to do better for our partners as well as for our patients. So just a couple examples there. Again, and many of you, although I see things coming into the chat, so thank you. I see Vicki just popped in for Nate. We have these discussions all the time when we're meeting, and you make me aware of what you're seeing in probation, parole, in the courts, things that you are wondering, could we look at it differently? So with that, I guess I will go to the next slide. And we can start the community discussion. And so again, I'm playing the role of facilitator here today, and I've written down the things in the chat. So I guess I will just go back there and kind of start there with some of the things that have come in. So one of the questions right in the beginning, and Dr. Ryan or anyone, please jump in. Do we only treat heroin, opiate, or are we broader than that in substance use disorders? If someone wants to just kind of reinforce how and what we can do to help folks.
Sure, I'll take that one. So by and large, actually, individuals don't use just one drug or just one drug and not alcohol. So since inception, we have been a comprehensive addiction treatment organization. Myself, I'm board certified in all substance use disorder treatment, not just in opioids. It just so happens, obviously, that the origination of the organization occurred during the opioid crisis, and there's been an immense amount of focus on that because of the high mortality associated with opioids. We address any and all issues in our holistic treatment plans.
Yep, perfect. Thank you. Again, Jails was another question. I'm not going in necessarily the order the chat came in, but something came in. Are we doing any work in the jails, specifically delivering services? And I know Dr. Ryan and you and I, we've talked about this many times, but maybe on a broader level across the state.
Sure. So myself and a few others consult with some jail healthcare companies across the state of Ohio, serving several counties to improve the treatment of patients with substance use disorder in those environments. As I'm sure that those that either know them or work in them, can be very challenging. The patients can be very challenging. So we do work with a lot of the different jail settings in order to discuss treatment options either in or immediately after release. There are also some of our sites go and do in-jail assessments and some other things. So the answer is, by and large, is yes. We're very involved with that particular treatment setting.
Yep, absolutely.
Jean?
Yes, please.
Yeah, just on the jail piece, it's just to build on that a little more. It may be a separate topic, but related. I think this is a real challenge. One thing what we know from all of you is that, with the reason why we're specifically talking this with COVID is that there had been quite a disruption to systems, right? There may be folks have been furloughed or are given more work, or people have been let out of jails for various reasons because of the virus, and it's causing a lot of chaos, or it's hard to manage. So what we look at is what can we do as a provider to do our part to make it a bit easier in understanding the landscape in which you're operating. So in the jail piece, if you have those folks, what we are really engaged at all of our sites, especially in Toledo, at providing services when we can in the jail. And if that's just a matter of providing assessments and to ensure that they are transitioned to treatment to anywhere, whether it's BrightView or to anywhere, we know the transitions of care is certainly important. Given the nature that, and as we talked, we've really ramped up our virtual capabilities. Telehealth we've done for a while, but we have the ability to do that. It's sometimes making sure that the jails have that capability too. So one thing I would say, and it can be part of the questions, is if you're in that system, is that this probably is going to be a long-term need, in having that capability, meaning making sure internet is viable, HIPAA compliant rooms, the technology in order to do those kinds of things virtually, and to let you know that BrightView, one way or another, will help champion that in the community, for us and for all providers that provide the service. So let us know through Jean and how we can help, but knowing that is still going to be a major need.
Thanks, Nate, for jumping back in. That's great. Another one that I'm going to jump to is transportation. Someone asked, can you help with transportation and talk a little more about case management? So, do we link people to other services as you outlined? They have other needs. Anyone can take it.
I think Dr. Kang would do great with transportation. He and I have been working on it a lot, and he's been very intensely involved with it lately.
Okay.
Yeah, I'll take case management too, since that group reports up to me, and clarify a little bit with the case management specialist function as well. I see a few questions in the chat there. So yeah, we certainly can help patients with transportation. Our case managers work inside of our centers, so we don't provide transportation in that we go pick patients up in our personal cars. We don't do that kind of case management. Instead, for current patients, we are able to provide them with transportation using rideshare or other technology. And so we are in the process of launching actually a pretty cool NIH NIDA study with the University of Pennsylvania. Kickoff is actually tomorrow, where we're going to be studying the impact of transportation access on patients' access to outpatient addiction treatment. I think most of us could probably hypothesize that more transportation would be helpful, but we're actually going to study it and make that contribution to the literature. But yes, we can certainly help to problem solve transportation barriers for our current patients, and our case managers would do that. Also, our case managers will link patients to other services. So it is actually one of the outcomes that we seek to track is do our case management staff effectively link patients to other medical providers? What we know is that when it comes to connecting patients to primary care or to other specialties, we do a very good job of that. there is a statistically significant change that happens in patients' engagement with other outpatient medical services in as soon as 3 months of starting with BrightView. And they also, on the same level, reduce their emergency room utilization by the same level, and they reduce their inpatient utilization, psychiatric and medical, in, again, an extremely statistically significant change. Where we have some room for improvement, candidly, is connecting our patients to dental care. And so that is something that we are putting further up onto their priority list is, yes, you guys do a good job getting patients signed up for insurance, connected to other healthcare providers at that outpatient level. Let's make sure that we also get patients connected to adequate dental services as well. That's just as important as everything else, frankly.
Hey, Dr. Kang, I'm going to jump because there's a question that kind of ties right to this, and then we'll move to a different area about case managers. How do they work with the child welfare system or some of the systems that involve, obviously, care of children where the parent might be using, et cetera?
Yeah, the case management specialist will provide the same feedback loop and reporting service that Nate has described for the justice system partners. So the child welfare services will get the same cadence and intensity of reporting. I don't know, Nate, if you want to add more to that, but simply the answer would be yes.
Yes, it is. And we, as Dr. Kang knows, we built that into our tracking. So we track both from a clinical standpoint, whether a patient is involved in criminal justice and or criminal child protective services. And I account for that in our reporting process equally. So.
Great. I'm going to jump to Joe's question. I think it's a great one, Joe, because we kind of tagged this presentation with COVID. So you're kind of inquiring, what have any of you seen in the past year or two relative to the clients that are presenting? What has COVID done to us and to anyone in the area of healthcare? And how do we use our three-pronged model, medical, social, and psychological? How are we pulling this all together, and what are we seeing, and what does the future look like?
I'll give just a brief answer, and maybe Dr. Kang might have a few thoughts. I mean, by and large, we know that COVID had the potential to and is substantially impacting in a negative way folks' mental health and addiction issues. We're seeing overdoses, primarily from opioids, but other issues go back up, unfortunately, where we thought we had actually kind of hit a plateau in the state of Ohio. And so it's likely that the stress of this pandemic is going to continue to worsen those issues more likely than not. And so what we're doing, several things, and it's a very comprehensive approach to try to address those issues for our patients. But by and large, it's moving further to meet the patient's needs where they're at. So trying to develop BrightView Virtual and increase our telehealth capabilities to meet those patients, and working with them on things like data plans and smartphones and whatnot, looking at other technological advances that may further support them during this time of separation from both their treatment provider as well as several of the other community connections, resources, family, et cetera. And then making sure that they know that treatment is still available, that we're still here. We're accessible through more routes than we ever have been, and in more robust ways than we ever have been. So we're really doing quite a lot to engage those patients that we know are going to have those challenges. I'll give you just an example of mine. I still see patients every week. And I had an older African-American patient who'd been in jail or prison, for quite some time prior to entering treatment. And he told me that his biggest stress in having to be in his house as a person with significant comorbidities, having to really isolate himself, was he felt like he was back in prison. And that created a substantial amount of stress for him. And he's done okay, but has had some struggles in his recovery because of that challenge that I honestly didn't even think about necessarily before being introduced to that issue by him. So we're doing everything we can, but these are challenging times. And so we'll just keep on expanding our access as much as we possibly can. Dr. Kang, any other thoughts?
Yeah, I think, we became quite concerned as soon as we started to grasp the severity of the pandemic, and knowing that we were already in the midst of managing this epidemic of addiction, the addiction crisis across our communities. we knew how much more challenging the work would become in serving the patients that we were already responsible for providing good care to, and then also could just start to predict a little bit of the challenges that, frankly, the rest of us would be confronted with. I don't know that anybody would have, even in mid-March, had a great understanding of how long this thing is going to go on for, and just the depths of the challenge. But we wrote a couple of national and local opinion and editorial pieces, trying to forecast and just shed light on the surge in mental health need that's going to be confronting not just behavioral health providers like ourselves, but frankly all people in our society. And so I think the state has done a tremendous job in terms of preparing for that. In terms of surge capacity, staffing, workforce development, and really trying to get as far ahead of the wave as possible. And so, as Dr. Ryan said, we're trying to innovate our services inside and outside of our centers to be as responsive as we can.
Thank you. I'm going to jump to a question from Eddie to you, Dr. Ryan, and he's over at St. Luke's EAP. He's asking about preference for Suboxone, films, tabs, kind of getting into the detail of Matt's services. And, it looks like he's experienced, there's some pushback or perhaps not as cost effective in using the films. So just Matt in general.
Sure, it's a pretty specific question about buprenorphine. I guess I'll say, I'll reiterate what I said before, which is we really do extensively evaluate the best options for our patients. And that includes, by the way, I'm sure some folks are familiar with the injectable form of Suboxone or buprenorphine that can be utilized for a multitude of reasons, including diversion control. Unfortunately, it's actually the insurance companies that often dictate what type or form of medication and the cost related to that. So we do have patients that we have to do prior authorizations and switch from pills to films to whatever version of that we might need for them. If it's a tolerance issue, some of them can't tolerate binders or taste or whatnot. So we to summarize, we really do individualize, but often the biggest barrier to us giving the most determination, and this is not unique to this type of medicine, is really what their insurance company dictates as the primary modality we need to use.
Great, thanks. Another question popped up earlier in the chat. I think we answered part of it, but not all of it, which is, do we help the uninsured? And I made comment to our foundation, and do we assist people getting into or onto Medicaid, et cetera? So kind of case management question again.
Yes. So we have never turned a patient away for an inability to pay. We have never turned a patient away for accruing a bill or something along those lines. So access has to be at the front of this conversation alongside quality. We've always believed that, and that will always be the case. And so I think, as Dr. Ryan likes to say, we accept as many forms of insurance as we can find, and our finance team is consistently, I think, frustrated with us for challenging them to make sure that we are in network with as many plans and providers as possible. But I think everyone can appreciate that that is a very pragmatic barrier to folks being able to access care. So yes, we take Medicaid and all of the managed care Medicaid plans. We take commercial insurance, we take Medicare, and then we also provide treatment to patients who have no insurance. We offer a sliding fee scale. But again, none of that should ever serve as a barrier for someone to get access to life-saving treatment. And our case management team does have a specific responsibility to work with patients on getting access to insurance. But there is, obviously a patient responsibility to verify like who they are and a bunch of other details on themselves to actually get access. But yes, our teams work with patients on that every day.
Thank you, Dr. Kang. Vicki, thank you for taking a moment. And I think you put two questions in here that I know we've talked about briefly. One is kind of this gap from the seat that you sit in with making referrals out of the prison system specifically, where there needs to be a program or something for people who are still using marijuana, and there's kind of a gap there. And then also the bigger topic, which I think you put is your second chat, just again, and others I think I've discussed with as well, about the need for aftercare. They might not need treatment. They've turned the corner. Folks are doing well. And I think the question about peer support that we offer and others, how can we better serve folks who are out of treatment but still need guidance and help? So whoever wants to take those two.
Yeah, so from a peer recovery services standpoint, we have a peer recovery supporter on staff at each of our centers. That is a typical piece of our model and typical piece of our staffing. Just like we say, we should have medical providers, we should have nurses, we should have medical assistants. You got to have a front desk staff with a compassionate smile to greet people. We should have counselors. They should have a master's degree. We should have a peer recovery supporter on the team. It's all part of the standard BrightView model. So I think that that's probably pretty clear. Does that generally answer that question?
Yep, it does. And then the marijuana, the question, and someone who's on this call brought up to me yesterday, I don't know if this actually happens. It seems like it could, where someone is put in a group who is maybe using marijuana, and they're in a group with people using heroin. So again, not necessarily saying at BrightView, but what can we do so that people can check a box to say, we don't really think you should be using marijuana, but again, they've stepped down from much more severe situations.
Sure.
And they're still accountable to direct them into some kind of program.
Yeah, there's a few things with that. So one is we are pretty careful about how we compose our groups. I think it's one of those things that if you don't have intentionality on the patients who are specifically making up a group, then you can have folks who are not connecting to each other, and a group can kind of blow up. Patients will just stop attending because they don't feel connected to the other members of the group. So you have to be very mindful of the constitution of the group. The good part about that is that we offer so many group options over the course of the week that it's pretty easy to find not just a group time, but a group membership that a new patient can feel comfortable with. On the aftercare level, for patients who are generally doing well, or they have quote unquote completed treatment, meaning they have completed what has been required by the court, or they have completed what they agreed to do when they started treatment, we provide aftercare ourselves. We call it continuing care. We ostensibly consider the patient to be treatment complete, quote unquote, but they are still a BrightView patient. They typically come in once a month and engage in a group of other patients who are in continuing care. And so that is a way for folks to stay connected. And they're still technically then in treatment because they're still with us. But we look at that internally as an aftercare level of care, and that's how we communicate that to patients too.
Great. And I know Dr. Gambash, you're on, and you have a question about admitting privileges to hospitals and psychiatry in general. So there you go, to whoever can answer.
I'm not really sure what the question is, Gina.
Do we have admitting privileges to all the local hospitals?
Some of our providers have admitting privileges to local hospitals, kind of depending on their background, where they came from, that they work for us full-time or part-time. So it's not as simple as saying we have admitting privileges to all local hospitals.
Okay. All right. And then the other piece is, do we have a psychiatrist on staff, or general thoughts on mental health and how that all goes together with that, which I know you touched on earlier.
Dr. Kane, do you want to take that, or do you want me to?
Yeah, so I'll give two different answers, right? So one is, I think we have set a bar for ourselves that we will meet 90% of our patients' mental health needs with our current workforce. And so that is a quite diverse workforce when it comes to the medical team, as Dr. Ryan mentioned. If you work in an internal medicine, emergency medicine, if you work really in any healthcare setting as a physician or as a nurse practitioner, you encounter patients with behavioral health conditions, and you kind of have to get good at taking care of them. And so our team comes with that background naturally. Same on the clinical side with our counselors and our social workers. So that being said, 90% of our patients, we seek to meet their mental health needs inside of our system. The other 10% of patients, let's say someone with a severe and persistent mental illness, let's say they have schizophrenia, along with a substance use disorder, we would seek to collaborate with a mental health provider who can meet those higher complexity mental health needs. And we would continue providing their addiction treatment. All of that is to say that's what we currently do, though we are in the process of standing up our own psychiatric service line inside of the BrightView system as well. So that's the second answer to the question, is that we will actually then look to do 100% of the outpatient mental health need ourselves. Obviously, if a patient needs to be hospitalized, we would still look to partners who offer those services.
Absolutely. And with that, as we approach 2 o'clock, Katie, I'm going to ask if you just could forward to the last couple slides and kind of quick overview. I did put my information in the chat. I know many of you, but if you're on this call and we have not yet connected, I look forward to doing that. But again, just a quick slide. You'll get the PowerPoint deck. I know many of you asked for that, so I'm sure we can share that with you and push that out to all those that registered. But again, a quick overview on how BrightView can help. And then I think the next slide. Again, accessing care. We've touched on many of these points, but again, you'll get the deck. We have an appointment setting technology now on our website, if that's easier for folks, and maybe doing discharge planning or whatever, but our call center is open 24/7. And we just look forward to continuing to work with everyone on this call and other partners, because everything we just touched on says that we're in for, again, kind of a bump in the need to help people. So with that, does anyone have a closing comment that they would like to share with the group of our presenters? Okay, well, with that, I'm sure we all thank you. And again, I am always just a phone call or an email away. And if there's interest in doing this again, I guarantee we will look at that and continue to stay in dialogue with you. I really appreciate it. And everybody have a wonderful day.